So my task for the next few minutes is to introduce you to a patient. There's my disclosures. And this is a very good-looking Scotsman, B. McKell. He was very fond of all things Scottish, whiskey, deep-fried Mars bars, smoking quite too much, etc., and is now paying the consequences for that. So, 62-year-old man, an ex-smoker, he gave up with appropriate advice from his family. He has been known to be hypertensive from his mid-50s. He's well controlled on Perindapil, 4 milligrams a day, and his blood pressure is absolutely fine. His BMI is up, as you can possibly tell, and he's been trying to lose weight. Glucose is not a problem. He's not diabetic. So, the clinical issues started in January 2017, about just over 2 years ago. Positive stress exercise ECG because he was complaining of symptoms, and there was greater than 50% stenosis in 2 major epicardial coronary vessels, the LAD and the circumflex. They were treated successfully with angioplasty and stents, and he had symptom relief. So he was feeling much better, and you can see from his smiling face that this was a great success. When he was first presenting to the clinic, they did a full lipid profile, and his triglyceride was up a bit. So with raised triglyceride, HDL is borderline, and a high blood pressure, he would classify almost in the realm of what we call metabolic syndrome patients. But his total cholesterol was also elevated with an LDL of 155, and his hemoglobin A1C was there. So, the cardiologist treating him said, maintain your smoking cessation, take more exercise, and adopt prudent diet, whatever that might mean, where I come from. And he tried his very, very best. Continued on the antihypertensive medication, and came in and wanted to start on a dose of 40 milligrams of atorvastatin, but that was up titrated to 80 milligrams in line with the guidelines. So he was able to tolerate 40, so he was up titrated to 80. Everything was fine, but actually things started to go wrong earlier this year, and he experienced a myocardial infarction at a site distal to the stent in the left anterior descending. PCI was performed with stenting again, and symptom relief was there. Now, the lipid profile, this is on 80 milligrams of atorvastatin, was very reasonable, but this was somebody who'd had in a second event and was therefore in a kind of aggressive mode of atherosclerosis was taking place. LDL was 75 milligrams per deciliter. The HDL crept up a little bit at 55. The triglyceride was down because atorvastatin 80 milligrams will lower your triglycerides substantially. And HbA1c was 6.8%. He's lost a bit of weight, as you can see. And he's an avid reader of the press, looked up the new guidelines when they came out, and came to see his cardiologist and said, what are you going to do for me? These new guidelines suggest that I should be more actively treated than I have been. This is an individual in the very high risk category, and to some extent, we can discuss it, in the very, very high-risk category, depending on how you view the timing of those events and those interventions. Not in the polyvascular bed, but certainly in the coronary bed, this vascular path is not making good progress so far in terms of clinics. So if we move on and look at the guideline goals that are now presented to us, and I find these very exciting goals because they are challenging, but a statement really of where the science is, as was discussed yesterday. So the goal might be to go below 1.4 millimoles per liter, less than 55 milligrams per deciliter, with an LDL reduction of more than 50%. Now, he was on the cusp of that, as you might recall, going from 155 down to 75 just on the 50% reduction, but not below certainly 55 milligrams per deciliter. But is he a patient who experienced an event within 2 years? Well, Francois, is 2 years and 3 months appropriate? And we can discuss what that 2-year guideline might look like in terms of how expandable is it, plus or minus 6 months. And therefore, the goal would be a lot less than that. Less than 40 would be where we were. And is the remnant hyperlipidemia, the high triglyceride, a cause for concern as well? Because while it was reduced on statin, there is still an element of raised triglyceride that's present. So this is a straightforward, very frequent picture. But now we're in new territory with the guidelines as to where we should go. So I'm going to ask you to finish this case presentation a couple of questions, and this is one where you can choose. So everybody's got their iPad, and let us choose between the following drug options to be prescribed to B. Michael, who is now looking completely concerned, as you can see, about what should happen next, having read the guidelines. Option 1 is pretty much no additional intervention beyond the 80 milligrams high-intensity statin therapy, because he's roughly about 70 milligrams per deciliter, and you would argue that if he lived in Boston, they might say, well, that's okay, you are where you are. Or should we move to aducanumab, 10 milligrams per day, to see how far down that will get him, and retest LDL in 3 months, but then he'll be in back in general practice, and what will happen to him then? Or do you proceed to say, look, let's not mess around, let's add a PCSK9 inhibitor, because we know that will take you down to 30 or 35 milligrams per deciliter from where you are, and we would have success in a single step? Or do we say, well, we believe reduce it, let's add EPA at 4 grams a day, because you've got a triglyceride in the range 135 to 500, and you qualify for that particular treatment, which gave a 25% risk reduction in the Reduce It trial. So please vote on 1, 2, 3, or 4. Okay. I am pleased to see that not everybody is satisfied, or almost nobody is satisfied with the present situation. That's very encouraging, Francois. I think we're making progress. Adding ezetimibe and retest is the favorite way forward, and that is guideline recommended. And a significant number of you want to say, let's go straight for a PCSK9 inhibitor. And I think as a panel, let's discuss those options and the tying of those. A minority would add the fish oil. So that's a very intriguing and thought-provoking response. In terms of where you wanted to end up with this individual, in terms of encouraging him to reach the targets that are there in the press, or in the scientific press, are we going to say, well, we'll stick with the new US guidelines and go for less than 70, and that would satisfy us, less than 1.8 millimoles per liter? Are we going to adopt the new ESC guidelines and say, this is a very high-risk patient, he was 2.5 years between events, and therefore the guideline is less than 55 or 1.4 millimoles per liter? Or we're going to have to say, this is a very aggressive vasculopath, let's treat him as aggressively as the guidelines suggest and go to less than 40 milligrams or less than 1 millimole per liter. So please vote for 1, 2, or 3, and let's see what your collective opinion looks like in terms of targets. Thank you. Okay. We are not too happy with just saying less than 70 is okay. The European guidelines have taken hold. And we're just about split evenly between less than 1.4 and less than 1.0.